Assalamu alaikum everyone. In this video we are going to talk about atrial fibrillation. It is very important topic. So what is atrial fibrillation? It is most commonly sustained cardiac arrhythmia which is characterized by multiple ectopic foci formation within the musculature of the atria, and these foci fires continuously and in a chaotic pattern, causing the irregular rhythm and rapid ventricular rate. The firing rate of the ectopic foci is more than 400 beats per minute, but due to delay in the AV conduction, so only few impulses reach the ventricles. That is from 75 to 175 beats per minute is the rate of ventricle. But due to so severe electrical activity, there is ineffective mechanical activity. So there are ineffective contractions of the heart. Now come to the causes of atrial fibrillation. The most common causes involves heart diseases like coronary artery disease, myocardial infarction, hypertension or high blood pressure, and congestive cardiac failure. All these are the causes which can contribute to the development of ectopic foci and ultimately atrial fibrillation. The history of cardiac surgery is also important cause. Because of the scar formation after the cardiac surgery, the scar can convert into the ectopic focus and it leads to atrial fibrillation. Pulmonary diseases like pulmonary embolism and COPD can leads to decreased oxygen supply to the myocardium, so ectopic foci formation can leads to atrial fibrillation. Hyperthyroidism, because in increased levels of thyroid hormones there is more sensitivity of the beta receptors of the heart, so there is overactivity of the heart, can also contribute to the development of atrial fibrillation. Systemic illness like severe illness like malignancy and sepsis can also leads to this disease. And alcohol directly damages the myocardium and also leads to scar formation, so leads to the development of atrial fibrillation. Other causes includes rheumatic heart diseases and pericarditis. Now come to the sign and symptoms or the clinical features. Because of ineffective contractions of the or musculature of the heart, there is reduced cardiac output in case of atrial fibrillation. So due to reduced cardiac output, patient feels fatigue, exertional dyspnea or shortness of breath on exertion, palpitations due to so severe electrical activity, and angina or syncope, both due to decreased perfusion of the heart as well as brain. So the pulse in this case is irregularly irregular pulse. This is a characteristic feature of atrial fibrillation. Now come to the complications of atrial fibrillation. The most common and the significant complication is due to ineffective contraction. There is a stasis of blood in the chambers of heart, which leads to thromboembolism, and this thromboembolism can ultimately leads to stroke formation in the vasculature of the brain. And the second complication is hemodynamic compromise due to reduced cardiac output, that is decreased blood pressure due to reduced cardiac output and also chest pain. So these are the features of hemodynamic compromise in case of atrial fibrillation. Diagnosis is usually done by the electrocardiogram. The ECG shows irregular RR interval. Now look at the ECG of atrial fibrillation. As you can see here, the gap between the RR interval is different, is vary from one RR interval to another RR interval. There is a short distance in between this RR interval and there is a little bit longer distance between this RR interval. So there is irregular RR interval and there is a wavy baseline. Now look at this baseline. The baseline looks like wavy pattern, and there is P wave cannot be appreciated in case of atrial fibrillation. So these all are the features of the atrial fibrillation on the ECG. The pulse is irregularly irregular pulse, and the rhythm is irregularly irregular, as you can see in this ECG. Now come to the management of the atrial fibrillation. If the patient is hemodynamically stable, then the pathway of the management is different. But if the patient is hemodynamically non-stable or unstable, then immediate electrical cardioversion or immediate DC cardioversion is needed. Basically, cardioversion is delivery of shock that is in synchrony with the QRS complex. The purpose of this shock is to terminate the cardiac dysrhythmias. This is immediately done if the patient is hemodynamically unstable. But if the patient is hemodynamically stable, there is no chest pain and the blood pressure of the patient is normal, then the first step is control the rate of the heart. So this heart rate is controlled by beta blockers like esmolol and metolol. And if the beta blockers are not available due to some reason or contraindicated like in the asthma, then the next option is calcium channel blockers. These are alternative to the beta blockers. These CCBs include diltiazem and verapamil, which mainly acts on the heart and reduces the heart rate. Other options includes digoxin. This digoxin is basically positive inotropic agent. Then next step is to check the duration of atrial fibrillation. If the duration is not more than 48 hours, then there is no need to give the patient anticoagulation, because as we have discussed, in these patients there is a risk of thrombo and embolus formation which leads to stroke. But if the duration of the atrial fibrillation is not more than 48, in short it is less than, in short we can say that the duration is less than 48 hours, then go to the cardioversion technique. We have discussed it earlier. So cardioversion is needed if the duration is less than 48 hours. But if the duration is more than 48 hours, there is a more risk of development of thrombus formation or the emboli formation, and ultimately leads to stroke. So if the duration is more than 48 hours, so if it is yes, then need anticoagulant therapy in these patients. Usually warfarin is used in case if the duration is more than 48 hours, because of the increased risk of thromboembolism in these patients. So after the warfarin therapy, give IV heparin at the time of cardioversion, and then cardioversion is performed, and then give the patient anticoagulation 4 weeks after this technique. If usually the doctor avoids the anticoagulation therapy and directly perform the transesophageal echocardiogram. And doctor obtained this echocardiogram to exclude the thrombi. If the thrombi is excluded, that is no thrombus is formed within the left atrium, then there is no need to give 3 weeks anticoagulation course. Just move towards the cardioversion, and then after cardioversion give the patient anticoagulation therapy for 4 weeks. But if the transesophageal echocardiogram shows thrombus in the left atrium, then give the patient anticoagulation as usual for 3 weeks, and then perform the cardioversion, and the end give the patient anticoagulation therapy for 4 weeks. So this chart is very important for the management of atrial fibrillation. Now come to CHA2DS2 VASC scoring system. It is very important to assess the risk of stroke development or risk of thromboembolism in the atrial fibrillation patient. If the patient is congestive cardiac failure, give the patient 1 score. If hypertension, 1 score. Age is more than 75, so this A2 shows the age, and C shows congestive cardiac failure. H is for hypertension, D for diabetes, S for stroke history, V is for vascular diseases, and A for age, and SC shows sex of the patient. So congestive cardiac failure 1 score, hypertension 1 score. If the age is more than 75 years, then 2 score, and it is major risk, more risk factor. So diabetes mellitus give the patient 1 score, stroke history 2 score, as it is a major risk factor. And the vascular disease is 1 score, age 65 to 74 1 score. And but if the age is more than 75, then 2 score. And if the gender is female, then 1 score. The total score is 9. So if the patient has, so this is the risk assessment for thromboembolism. So if the score is 0, that all these factors are negative, there are no risk factors in these patients, so this is called lone atrial fibrillation. This is lone atrial fibrillation with score CHA2DS2 score of 0. It means that there is no need to give the warfarin, just give the patient anticoagulant aspirin. So no need to give. If the patient has the score of 0, then no need to give the warfarin in these patient. But if the score is 1, suppose the patient has diabetes mellitus and no other risk factors, so which is equal to 1 score. So if the patient has diabetes mellitus or any other congestive cardiac failure is equal to 1 score, so in these cases either give the patient warfarin or give the patient aspirin. So if the score is 2 or more than 2, then in these cases warfarin is indicated. Now come to the management of chronic atrial fibrillation. The first step is same, that is control of the heart rate, which is usually done with the beta blockers. If not available, then calcium channel blockers, or if the blockers are contraindicated, then calcium channel blockers, and anticoagulation with the warfarin. But if the patient has lone atrial fibrillation, as we have discussed previously, that score is 0 in lone atrial fibrillation, means that no cardiovascular risk in these patients, and the age is less than 60 years. So in these patients, aspirin should be given because of the low risk of thromboembolism. So aspirin should be given in place of warfarin. So in these cases, warfarin should be avoided. Give the patient aspirin. This is called lone atrial fibrillation. So this was whole about the management and the clinical features and whole about the atrial fibrillation. Thank you so much for watching this video.